If you just got a PCOS diagnosis and you're not quite sure where to start, or you've been dealing with PCOS for years but nothing has ever quite worked to manage your symptoms, this is the masterclass for you. Hi, I'm Kara, a registered dietitian, and I make content for people who don't have the time, the money, or the desire to see a registered dietitian in person, but still want to know science-backed, evidence-based strategies to manage the things that are going on in their life or their health. So this masterclass is a compilation of a few videos that really dive into the different types of PCOS, figuring out which type you have, and how to effectively manage the symptoms that you are experiencing in a way that really works in your life. So there are some videos about the lab tests you need to get a diagnosis. There are some videos about specific diet plans for specific symptoms of PCOS. And I talk a little bit about how PCOS and insulin resistance really work together and make both of those conditions difficult to manage. So if that sounds like something you need, lock in for the rest of this video. It's going to be a long one, but by the end, you'll have a really solid foundation on some steps you can take to really manage what's going on with your PCOS. If you've been diagnosed with PCOS, you might actually be treating the wrong type. Most people don't know that PCOS isn't just one condition. It's actually 4 distinct phenotypes, and each requires a different type of treatment. I mostly focus on conditions related to insulin resistance, and today we're going to talk about polycystic ovary syndrome, or PCOS. If you don't have the time or the money to see a registered dietitian, this is the YouTube channel for you. I want to be transparent here. I do not have PCOS, but insulin-related conditions are why I became a registered dietitian, and I did my master's thesis on another estrogen-related condition called lipedema. So I hope that you can trust me when I say I care about you, I know a little bit about what you're going through, and I do really want to help you. So let's get into it. PCOS affects 10 to 15% of reproductive age females. Many of these folks go undiagnosed for a long time, maybe even most or all of their life, and PCOS is one of the leading causes of infertility. Patients with PCOS are more likely to develop hypertension, type 2 diabetes, hyperlipidemia, heart disease, endometrial cancer, and eating disorders, making early diagnosis and treatment really crucial for their long-term health. PCOS also increases the risk of miscarriage, preeclampsia, gestational hypertension, gestational diabetes, and cesarean deliveries. And because PCOS is a syndrome specifically, that means it is a condition characterized by a set of symptoms that may not always present exactly the same in all patients, and there is no unequivocal diagnostic criteria. Historically, the Rotterdam criteria has been used to diagnose patients with PCOS. The Rotterdam criteria has 3 key features that we tend to see in folks with PCOS. And to get a PCOS diagnosis, you have to be exhibiting at least 2 of the key features, if not all 3. Because patients can have only 2 of the 3 key features, we end up with different phenotypes, which is just our scientific word for flavors of PCOS. And what research is finding more and more is that treatment success really comes down to treating the right phenotype. Many patients receive a generic PCOS diagnosis without an associated phenotype. And many of these patients are prescribed clomiphene. And that is a prescription medication that blocks some of the estrogen receptors in the brain. So it kind of tricks our body into thinking we are not making any estrogen, which leads us to increase the amount of estrogen that we make, which can be effective if the problem that this patient is experiencing has to do with a lack of estrogen. But again, again, because there are those different phenotypes, it doesn't necessarily work for all of our PCOS patients. So understanding your phenotype can mean breakthroughs in your treatment plan. So I'm going to dig a little bit deeper into what the key features of the Rotterdam criteria are, what symptoms each phenotype tends to exhibit, and then I actually have a self-assessment tool that you can use to determine your own phenotype. And there is actually a link to the self-assessment guide in the description of this video. You can fill this out as we're walking through the video and actually take it with you to the doctor the next go. This might just be a handy worksheet for you to have some language to use with your doctor. The three key features of the Rotterdam criteria are: number one, irregular or absent periods, and this is referred to as ovulatory. The second key feature is high levels of androgens or hyperandrogenism, and this just means you are exhibiting higher levels of what we typically think of as male sex hormones as opposed to female sex hormones. The third criteria is a polycystic ovary or ovaries seen on ultrasound. And this is criteria that is widely but not always used by physicians to diagnose PCOS. A study released in 2022 recommended that physicians look at levels of anti-Muralian hormone or AMH, and that is because AMH is only released from ovarian follicles. So that is a very useful biochemical metric of if a patient has higher than expected ovarian follicles. And AMH can be read just by doing a blood test, which tends to be less expensive, more accessible, and less invasive than having an ultrasound done of the ovary. So let's dig a little bit deeper into these three key features. Ovulatory dysfunction means irregular or absent ovulation. This could mean menstrual cycles that last longer than 35 days or fewer than 9 menstrual cycles in a year. It could mean missed periods, very light periods, or very heavy bleeding when you do have a period. Now, there are other things, including genetics, stress, change in environment, not eating enough calories to support your activity level, and even drugs that can change your menstrual cycle. So that alone is not enough to diagnose PCOS, which is why we have these other two potential criteria as well. And the next one is that hyperandrogenism. And doctors can observe hyperandrogenism either clinically, which means looking at the signs and symptoms, or biochemically, which again means taking your blood or taking a sample of another tissue and looking at the actual amount of those male hormones circulating in your body. And those signs and symptoms of these high androgens might be things like hair growing in places that it typically doesn't on females, or even male pattern baldness. And then again, that third criteria is those polycystic ovaries, which means 12 or more follicles or an ovarian volume of more than 10 mLs. Now, depending on which of these key features are presenting in your type of PCOS will determine your phenotype. Phenotype A, or classic PCOS, is when you are exhibiting all three features on the Rotterdam criteria. This tends to be the most severe form of PCOS. It has the highest rates of insulin resistance, the greatest metabolic disease risk, the highest cardiovascular disease risk, and it is the most resistant to that clomiphene treatment that we talked about earlier, and it often presents with obesity and lipid abnormalities. Phenotype B is non-PCO PCOS. This is if a patient is experiencing hyperandrogenism and ovulatory dysfunction, but they don't have those polycystic ovaries or that high AMH level. So there's a significant hormonal imbalance, but no ovarian cysts. Folks with phenotype B have more of an intermediate metabolic risk, so not nothing, but not as high as the folks who have phenotype A. They have stronger hyperandrogenic symptoms, which means they may be experiencing more of that excessive hair growth, or the opposite end of the spectrum, maybe even hair loss. Typically, ovulatory dysfunction is the primary concern for this group, and unfortunately, there is less research available compared to the other phenotype for phenotype B. Phenotype C is referred to as ovulatory PCOS. These folks have hyperandrogenism and polycystic ovaries, but they have normal ovulation. So these folks have regular menstrual cycles despite their PCOS diagnosis. They have lower insulin resistance rates, milder metabolic disturbances. The focus for these folks tends to be on androgen excess management. They may have lower risk of endometrial cancer, and unfortunately, they are often overlooked because they are still experiencing a regular menstrual cycle. And phenotype D is the normoandrogenic PCOS. You have normal androgens, you don't have those high levels of male hormones, but you are experiencing ovulatory dysfunction and polycystic ovaries can be observed. This tends to be the mildest form of PCOS, and I do not mean that it is not causing significant issues in your life, but as compared to some of the other forms, some of the health risks are just a little bit lower if this is the phenotype of PCOS there's the lowest metabolic risk, there's no signs of excess male hormones, there is a better response to fertility treatment typically. Now here's where we get to the self-assessment checklist. Again, I have a form that you can download from the link in my description box. There is a little bit more information that might be useful to your doctor if you take it in. Otherwise, you can just follow along as I ask you a few questions about your symptoms to try and figure out your phenotype. Have you ever experienced irregular periods, meaning cycles longer than 35 days or fewer than 9 periods in a year? Missed periods for 3+ months, not due to pregnancy or menopause, and or have you ever had difficulty tracking ovulation or getting pregnant? If you said yes to any of those questions, you have signs of ovulatory dysfunction. Okay, next group. Do you have any of the following? Excess facial or body hair, persistent acne past adolescence, thinning hair or male pattern baldness, blood tests that show high testosterone or DHEA. If you said yes to one of those, you are showing signs for hyperandrogenism. Now, last group. Have you been told you have polycystic ovaries based on a pelvic ultrasound? This refers to appearance, not actual cysts or pain. And or have you been told you have elevated anti-Muralian hormone higher than 3.9 nanograms per ml? If you marked yes for either one of those two questions, you are showing signs for polycystic ovarian morphology. Now, let's analyze your result. If you said yes to all 3 categories, you may have PCOS phenotype A. If you said yes to the first 2 sections, but not the third, you may have phenotype B. But if you haven't had an ovarian ultrasound or an MHA reading, you may want to get that done to distinguish between phenotype A and B. If you said yes to sections 2 and 3, you may have phenotype C. If you said yes to sections 1 and 3, you may have phenotype D. Now, as both medical professionals and patients, we want to make sure that we are personalizing your treatment plan so we can actually address your symptoms and your goals. For example, if you don't need to be on medication for insulin resistance, then putting you on an insulin resistance medication could cause dangerously low blood sugar or lead to nutrient deficiencies. If you don't want to get pregnant, then your treatment plan probably is going to look different than if you do want to get pregnant. And phenotyping is really useful. 49.1% of people diagnosed with PCOS actually have PCOS phenotype D, but are being treated as if they have PCOS phenotype A. And phenotype D only has a 38% risk of insulin resistance, as opposed to phenotype A, which has a 91% risk of insulin resistance. So the treatment plans there probably look a little bit different. It's important to understand all this shit when we are talking about diet, lifestyle, and medications that you may manage until you hit menopause or even maybe for the rest of your life. A little bit more here on the treatment for each phenotype. Phenotype A requires aggressive metabolic management, which might mean something like metformin or even a GLP-1 medication. Phenotype B focuses on hormonal balance and ovulation, which means, again, you might be the best candidate for that clomiphene medication which tends to be the first line medication for PCOS, but isn't necessarily appropriate for everyone. If you have phenotype B, it might also be best managed with hormonal birth control, hormonal replacement therapy, or anti-androgen medication. Phenotype C prioritizes androgen reductions, which might mean insulin resistance drugs like metformin or GLP-1s again, like phenotype A. It might mean hormonal birth control, anti-androgen meds, or it might even mean surgery if you are hoping to get pregnant. Phenotype D requires milder ovulation support and probably wouldn't require or meet the criteria for metformin or GLP-1 weight loss medications. This is probably the group that is most often referred to as lean PCOS. However, these folks might benefit the most from hormonal birth control or ovulation induction if your goal is to get pregnant. Now, I do want to leave you with the fact that I am not a doctor. I am a registered dietitian, and so I am legally not allowed to diagnose PCOS or a phenotype, and I'm not qualified to recommend specific medications. I am only here to educate on the different options that exist and translate medical jargon to the everyday person. But I hope that this gives you some options to explore with your medical care team, and I hope it gives you some hope that just because one treatment plan didn't work doesn't mean that nothing will or can work for you and the symptoms that you are experiencing. So I would love to know if this helped you determine your potential PCOS phenotype and if you think that you have been treating the right phenotype. Now, despite not being qualified to diagnose PCOS, as a registered dietitian, I am qualified to provide nutrition and lifestyle recommendations for the treatment of PCOS. For some people, nutrition and lifestyle management is going to be enough to deal with the symptoms they are experiencing. However, for some people, they are going to need nutrition and lifestyle to accompany their medication treatment. If your PCOS diet isn't working, it's probably because you're treating the wrong phenotype. 70% of women are following diets that don't match their metabolic needs, and I am about to show you the solution. Most PCOS advice ignores differences between the different phenotypes of PCOS. For example, 92% of people with phenotype A have insulin resistance, but only about 38% of people with phenotype D have insulin resistance, and therefore the treatment plans for those folks probably should look different. Another example is that not everyone with PCOS needs to lose weight, and not everyone with PCOS is trying to get pregnant. Those treatment plans are going to be different based on the appropriate goals for the individual patients. Now, if you don't know what I'm talking about when I say phenotypes, I highly recommend you go back and you watch my first video on PCOS phenotypes and try to figure out which one you are maybe experiencing, and then come back to this video for the best nutrition advice for your phenotype. Now, first, let's talk about weight loss, because I think most people who have PCOS or suspect they have PCOS, the first recommendation they get is to lose weight. There is some research evidence to support that weight loss is appropriate for people who have PCOS and obesity. However, the recommendation for PCOS is about a 5 to 10% body weight reduction in folks who have a BMI over 30. Now, when it comes to metabolic benefits and weight loss, the recommendation tends to be somewhere between 5 and 20% of the original body weight, depending on what is necessary for you. I don't have phenotype-specific weight loss recommendations, so talk to your doctor about what might be the right number or the right goal for you. If you currently have a healthy body weight, so a BMI between 18.5 and 25, weight loss is not necessarily appropriate for you. Also, if like me, you have a BMI between 25 and 30, but you are highly muscle, then weight loss is probably not going to be the right option for you either. We want you to keep that muscle mass. Just because you have a BMI between 18.5 and 25 doesn't necessarily mean you're following the best diet and lifestyle recommendations. If you want to know more about that, you can watch my video about health at every size, which goes in depth about how behaviors, rather than a specific number, are actually what tends to be most supportive of our overall health. And if you do think that you need to lose some weight as part of your PCOS management, I highly recommend working with a registered dietitian because folks with PCOS have been shown to have higher rates of eating disorders, which can also be really detrimental to your overall health, especially your mental health. After I go over the specific phenotype recommendations when it comes to diet, I am also going to give you one tip that I recommend for everyone with PCOS. Let's talk about phenotype A and phenotype B, which have higher risks of developing metabolic diseases, things like type 2 diabetes and heart disease. Phenotype A, when you have all three characteristics of the Rotterdam criteria, tends to have the highest risk of insulin resistance. And phenotype B tends to have hidden metabolic dysfunction, but without that ovarian morphology. The guidelines that I mentioned in the intro recommend that these two phenotypes see the best results when they are following a Mediterranean diet with a sustainable caloric deficit if they are in that weight category that would benefit from weight loss. The guidelines recommend for phenotype C, androgen-focused nutrition strategies, and for phenotype D, they recommend cycle support and general health optimization. For these two phenotypes, C and D, there tends to be lower metabolic risk, so standard healthy eating patterns tend to be sufficient. That would be things like following the Dietary Guidelines for Americans MyPlate recommendations. Now, this might sound disappointing or like it's not enough to go off of, but I would disagree. According to the Dietary Guidelines for Americans, most adults in the United States would only score a 56 or a 59 out of 100 if they were tested on following the MyPlate recommendations. So there is some room for improvement for most adults. Most adult females are not eating enough fruit, vegetables, or dairy. Younger adult females, 19 to 30, don't eat enough grains overall. Older adult females are eating enough grains, but most of their grains are refined grains, not eating enough whole grains, which is what we would recommend for people with PCOS. I know that many of us who are struggling with insulin resistance have been told to cut carbohydrates, but that is not exactly the approach that I would take. The Mediterranean diet and the DASH diet, which I mentioned for phenotypes A and B especially, they do include reasonably high amounts of carbohydrates, largely fruits, vegetables, and whole grains. Most females are also exceeding the recommended intake for added sugars, saturated fat, and sodium. In addition to optimizing the intake of those food groups for PCOS, those food groups also tend to increase the risk of developing things like cardiovascular disease, which is the leading killer of females worldwide, including women with PCOS. So those were the general guidelines. Let's dig a little bit deeper into some specific recommendations for each phenotype. For phenotypes A and B, the Mediterranean diet with a 5 to 10% weight loss target is recommended. Now, the Mediterranean diet emphasizes plant-based foods like vegetables, fruits, whole grains, legumes, and nuts, along with healthy fats like olive oil. It also includes moderate amounts of fish, poultry, dairy, and eggs, while limiting processed foods like added sugars and red meat. So again, sounds pretty close to the general dietary guidelines for Americans as well. The Mediterranean diet also often includes red wine. For folks with PCOS, it is recommended that you skip the red wine and instead prioritize green tea for the polyphenol benefits. The international guidelines also recommend for phenotypes A and B supplementing with 1 to 3 grams per day omega-3 fatty acids to help with inflammation reduction. They recommend for these groups protein timing around resistance exercise, and around 25 to 30% of the daily calories come from protein. And that protein doesn't necessarily have to all be meat. Again, you are going to get some protein from dairy, from some certain types of whole grains, and even from some vegetables. A low glycemic index diet might be appropriate for phenotypes A and B. Glycemic index refers to the level to which blood sugar will spike after you eat a certain food. Foods with higher fiber in them, like whole grains, tend to have a lower glycemic index because the fiber slows down the carbohydrate digestion, which in turn flattens that blood sugar curve. Phenotype C is considered moderate risk, and the nutrition recommendations really center around anti-androgenic foods, which would be things like spearmint tea. 2 cups of spearmint tea is recommended per day for phenotype C, as well as 1 to 2 tablespoons of flaxseed per day. Balanced macronutrient breakdown is recommended for this group, so we're not cutting out carbohydrates entirely. We're not doing a really low carbohydrate or a really low fat diet, but rather about 30% of your calories coming from protein. And then for balance, I typically recommend around 40% of calories coming from carbohydrates and that last 30% of calories coming from healthy fats. But personalization on what exactly that balance looks like is going to be really important for the sustainability of the diet for you. For phenotype C, they also recommend strategic carbohydrate intake, especially around ovulation. Ovulation is something that takes a lot of energy out of our body, and carbohydrates are the primary fuel for all of our body's tissues. And so we don't want to be really reducing carbohydrates, especially around that time in our menstrual cycle when we are ovulating. Zinc is also a really key nutrient for androgen balance. So things like pumpkin seeds and lean meats do tend to have high amounts of zinc. Phenotype D tends to be a lower metabolic risk group. And so a nutrient whole food diet without calorie restriction tends to be what's most appropriate for this group. Nutrients that support the menstrual cycle, including iron, B vitamins, and magnesium, tend to be recommended. We can get all of these nutrients through foods. Iron we can get through lean meats or some plant-based sources. B vitamins, again, we tend to get mostly from carbohydrates. B12 we specifically get from meat, and magnesium we can also get through plants, fruits, vegetables, leafy greens. Now is a good time to mention that lentils are a really good source of all 3 of these nutrients, so can be an important inclusion in your diet. The focus for this group should be minimal restriction and maximum sustainability. So we are not talking about doing something for 30 days, following a diet plan for 75 days, 3 months, even a year. We are really talking about building a dietary pattern that you can follow most days until you hit menopause, maybe even for the rest of your life. The international guidelines also recommend regular meal timing to support natural ovulation. So that means not doing something like fasting. We want to be eating regularly throughout the day, regularly throughout the week to support ovulation. The 2023 guidelines also remind us that there is not one superior diet for all 4 phenotypes. You may be receiving recommendations on diet that are just not appropriate for the way that your PCOS presents. Individualization trumps rigid phenotype protocols, and cultural and personal preferences are important for sustainability. For example, we can get similar nutrients from really any kind of leafy green. I really don't like kale. I much prefer spinach or collards. And so if I am trying to get those nutrients, it is going to be better for me to get them from the foods that I like rather than listening to someone who says, you gotta eat kale, because you probably don't have to eat kale.
They could find out kale cures cancer and I would still be like, I'm just gonna do the chemo.
And you probably don't have to eat any one specific food that you don't like. The guidelines also recommend behavioral support as a crucial piece, no matter which phenotype classification you're in. And that behavioral support might come from a partner or a friend or peer support group. It might come from working with a registered dietitian, doctor, depending on your circumstances. But long-term management of a chronic disease like this just oftentimes takes support when things get complicated and life tries to get in the way. We are also reminded that there is limited evidence for phenotype-specific dietary intervention. And that is because when research studies are being done on patients with PCOS, the phenotypes are oftentimes pooled. So we don't have hard and fast guidelines for any phenotype. Rather, what we've talked about to this point is based on the best evidence that we have to this point. Because research is limited when it comes to specific phenotypes, some practitioners and some patients choose, rather than implementing a diet for a phenotype, they pick a symptom or symptoms and they aim to follow a diet that is going to be useful for those specific symptoms. I'm not going to walk through this entire chart, but let's look at 2 different symptoms and kind of walk through what we know might be some good diet and supplement choices when it comes to those symptoms. If you are experiencing hirsutism, that is a really hard word for me to say. It just means hair growth in places that is atypical for females. So if you have, excessive hair growth on your face, on your chest, tends to be in places where males more often grow hair. The recommendation for diet is calorie restriction. If you are in those higher BMI categories, calorie restriction is never appropriate for someone who is already at a healthy body weight. There may be some useful supplements, however, to combat that hair growth: magnesium, zinc, calcium, vitamin D, and myo-inositol. Myo-inositol is often recommended for PCOS, and for certain symptoms it is useful, and for certain symptoms it's just not the right supplement. With a thoughtful diet that follows, the dietary guidelines for Americans or the Mediterranean dietary pattern, magnesium, zinc, and calcium, we can typically get enough of those nutrients from our diet. Vitamin D is really difficult for adults to get enough of, and so oftentimes for several different chronic conditions, vitamin D is a useful supplement. And myo-inositol, you're going to want to get this supplement form if you think that is going to be useful for your symptoms. When it comes to herbs, green mint and licorice smooth have been shown as useful herbs. I know that both of those are oftentimes seen in tea. Now let's look at another symptom: insulin resistance. If you are trying to treat insulin resistance specifically, a high fiber diet with reduced glycemic index would likely be appropriate to address your insulin resistance if you have PCOS, and probably even if you don't have PCOS. And again, reduced glycemic index just refers to foods that are not going to spike your blood sugar as high, and so it makes sense that those foods are going to be higher in fiber. They also recommend reduced calories for this group if weight loss is appropriate. Vitamin D and myo-inositol recommended here again for insulin resistance, as well as a berberine supplement. Berberine has been used for centuries in traditional Chinese medicine and has been shown to be beneficial for blood glucose support. When it comes to herbs, if you are treating insulin resistance, aloe vera, cinnamon, green tea, chamomile, and white mulberry might be useful for you. If you get on Google or Reddit or TikTok, there is so much information about what to eat or not eat if you have PCOS. Not only can it be confusing, it can just be inappropriate for the symptoms or the phenotype of PCOS that you are experiencing. So I hope that this video has helped you clarify, organize perhaps, and just see some of the evidence-based recommendations that match your symptoms and your goals. I would love if you dropped your phenotype in the comments and tell me your biggest dietary challenge. I may actually be able to give you some recommendations just through the comments. And please subscribe if you would like more evidence-based PCOS content that cuts through the online confusion with real research. We are breaking down the most important lab tests if you are being evaluated or managing PCOS by phenotype. Whether you're just starting your PCOS journey or feeling confused by your lab tests, this video will help you understand what you're testing and why. Stick around to the end. I will also share a free downloadable lab test checklist that you can bring to your next appointment. Now, this channel is all about providing evidence-based strategies to reduce your risk or manage chronic chronic diseases without the time or expense of seeing a registered dietitian in person. If that sounds useful, then this is the channel for you. So let's start with the basics. PCOS is not just a one-size-fits-all diagnosis. There are 4 different phenotypes or flavors of PCOS, as I call them. And the flavor of PCOS that you have is really important to understanding the most effective and useful tests for you. So let's do a quick recap. PCOS phenotype A is when patients are exhibiting symptoms of all 3 of the key features of the Rotterdam criteria. This includes irregular periods, high androgen levels, and polycystic ovaries. Now, phenotype B is called non-PCO PCOS, and this is when patients are experiencing irregular menstrual cycles and high androgen levels, but they don't have those polycystic ovaries. Phenotype C is called ovulatory PCOS, and this is when patients have high androgen levels and polycystic ovaries, but they still have a normal menstrual cycle. And phenotype D is called normoandrogenic PCOS, and this is when patients have an irregular menstrual cycle and polycystic ovaries, but their androgen levels are about normal. If you don't know what I'm talking about when I say PCOS phenotypes, or you're just not sure of your phenotype, I highly recommend going back to my first video in the PCOS series, which really does a deep dive into the phenotypes and has a free downloadable self-assessment guide that you can use to figure out which phenotype you are experiencing. I'm going to first talk about the lab tests for PCOS that everyone should be getting done, and then I will go phenotype by phenotype. So first, I recommend all PCOS patients have their testosterone, both free and total testosterone, tested. Total testosterone measures the amount of both bound and free testosterone in the bloodstream. Free testosterone reflects the bioactive portion of testosterone that is not bound to a blood protein. High levels of free testosterone is more accurate in predicting hyperandrogenism, which is what we see in PCOS. Now, the lab test is part of how doctors can diagnose that feature of the Rotterdam criteria. Doctors can also diagnose hyperandrogenism simply by looking at signs and symptoms that you are experiencing, which could be things like abnormal hair growth or even male pattern balding and acne beyond adolescence, which all tend to be associated with higher levels of testosterone. The next test that everyone should be getting done is DHEA or DHEA-S. DHEA is also primarily a male sex hormone, but instead of being produced in the reproductive system, it's actually produced by the adrenal system. If your DHEA is high, you may experience some of the same symptoms as if you had PCOS, but because it is the adrenal system that is overproducing those male sex hormones, it may be something like Cushing's disease or maybe even a tumor, and so it's really important to understand the difference. All PCOS patients are also going to want to test their LH to FSH ratio. This looks at the relationship between luteinizing hormone and follicle stimulating hormone. Luteinizing hormone is primarily responsible for ovulation. Follicle stimulating hormone plays a role in our menstrual cycle as well as egg maturation. Low or normal follicle stimulating hormone with elevated luteinizing hormone may suggest PCOS. A greater than 2-to-1 or 3-to-1 ratio of LH to FSH is typically seen in PCOS patients. The next test you'll want to have done is prolactin. And prolactin is the hormone that stimulates breast milk production. And if it's elevated, it can suppress ovulation. Now, biologically, that kind of makes sense. If you've just given birth and you are still breastfeeding an infant, your body is probably not ready to, ovulate and potentially get pregnant again. So that hormone turns on the milk and turns off the eggs. Now, if you haven't recently given birth and your prolactin levels are high, that could be indicative of a pituitary disorder. So just like if you have high levels of DHEA, it's not necessarily related to your reproductive system. If you have high levels of prolactin in the absence of a new infant, it could be indicating that something is wrong with a different system in your body, but is related to to your menstrual cycle. Folks who are experiencing irregular menstrual cycles may also want to get their thyroid stimulating hormone tested, or TSH, and that's because abnormal TSH levels can mimic PCOS, but again would be a different biological system causing those issues. I would also recommend that all PCOS patients regularly check their HbA1c and fasting insulin, which is a little bit different than getting your fasting glucose tested. Insulin resistance is incredibly common in all PCOS patients, even if they are pretty lean. Now, HbA1c reflects average glucose levels over the last 2 to 3 months. It's one of the most common tests we use for prediabetes and diabetes. It's also good to test fasting insulin rather than fasting glucose levels, because when we first start to experience insulin resistance, our body can sort of make extra insulin to keep our blood sugars in the appropriate range. And that is called compensatory hyperinsulinemia. Now, if you've ever known someone who was maybe losing their hearing, and in conversations you start to talk a little bit louder so they can still hear your message, that's sort of the same thing as what the pancreas is doing when your tissues start to not respond to the levels of insulin you were producing for. It produces more insulin in order to have the same message heard. Just like you might give up on that conversation after you've been shouting for some period of time, your pancreas eventually will also give up on producing extra insulin, and that is how we progress from compensatory hyperinsulinemia to diabetes. So even if your blood sugar levels are normal when you do a fasting blood glucose test, you want to test insulin to understand if you're using an abnormally high amount of insulin in order to achieve normal blood glucose levels, because that is going to be another indicator that you have some level of insulin resistance. And if we can catch that early, then there are steps we can take to reduce your risk of developing diabetes and also probably slow or stop your progression of PCOS. I also recommend that all PCOS patients get a lipid panel done regularly. And a lipid panel is just looking at the amount of fats in our bloodstream. This is when we look at triglycerides, cholesterol levels, LDL cholesterol, which is considered or sometimes called bad cholesterol, and HDL cholesterol, which is sometimes called good cholesterol. I recommend this because cardiovascular disease is the leading cause of death worldwide, but also insulin resistance is a major risk factor in developing cardiovascular disease. And because we know patients with PCOS tend to have insulin resistance, it also means patients with PCOS are at a higher rate or risk of developing cardiovascular disease. You already know your PCOS phenotype, you can just skip. They'll be in the chapters of this video. But don't miss the chapter that says come back here, because that is where I will get back into information that's relevant for everyone. If you don't know your phenotype, then feel free to watch all of the different chapters, but some of these tests are the same for each phenotype. So you may just hear about one test a couple of different times. So phenotype A, classic PCOS. If you have the classic trio of irregular periods, high androgens, and polycystic ovaries, you are in the group that has the highest risk level of metabolic condition. Things like type 2 diabetes, cardiovascular disease. So testing for that metabolic syndrome, in addition to the core PCOS tests, is going to be important as you manage your PCOS. So if you have phenotype A, something you might want to consider or talk to your doctor about is an oral glucose tolerance test. And an OGTT looks at blood sugar levels, but in a little bit different way than our HbA1c or fasting glucose or fasting insulin tests would look at it. If you take an OGTT, you will drink a glucose beverage. It'll be super sweet, and then there will be blood draws taken over a 2-hour period. And we look at how high your blood glucose goes and how long it takes your body to get your blood glucose levels back to a normal level. This can also give us an idea of how severe or how extreme your insulin resistance is, because we have a basic idea of how long it should take your body to handle a standard dose of glucose. And if it takes longer than that, that means that your body is not responding to insulin or producing insulin at the rate we think it would normally. If you're a PCOS patient who's already been diagnosed with prediabetes or type 2 diabetes, this is not necessarily a test that you need to do. However, if you have an abnormal oral glucose tolerance test, it might provide more support to getting a prescription for something like metformin, which has been prescribed for PCOS patients for a while now, or even GLP-1 medications, which do have some data to support the management of PCOS. If you have phenotype A, you might also want to have your liver enzymes tested regularly, and that is because people with insulin resistance have a higher risk of developing what's called non-alcoholic fatty liver disease. And this is where adipose tissue builds up around your liver, which makes it harder for your liver to do its job. People with PCOS type A might also want to have SHBG tested, and SHBG refers to the sex hormone binding globulin, which is just a scientific term for a protein in the blood that binds to our sex hormones, things like testosterone. When SHBG is low, it means that there is likely more of that free testosterone that we talked about in that first section. More free testosterone means that that testosterone can bind to our cells more often, and again, cause some of the symptoms of PCOS that are specifically related to testosterone levels. Now, if you do have low SHBG, typically oral contraceptives or metformin are prescribed, and that can elevate your SHBG. However, if you have endometriosis, the medications prescribed for that condition do typically lower SBHG, and some patients do have both endometriosis and PCOS, so you would definitely want to work with your doctor to balance the appropriate prescription for you. If you have phenotype B or non-PCO PCOS, you likely have irregular menstrual cycles and androgen excess, but you don't have polycystic ovaries. In addition to those core tests that I recommended at the beginning, I would also consider testing some of your adrenal indicators. So first, you might want to look at 21-hydroxylase. 21-hydroxylase is one of the enzymes that falls along the pathway that converts cholesterol to our sex, things like testosterone and estrogen. You might also want to have 17-OHP tested, which is one of the broad of these enzymes along that pathway from cholesterol to estrogen or testosterone. Now, if either of these two tests are low, it may be an indicator that while you're experiencing some of the symptoms of PCOS, you may actually have something going on with your adrenal system. It may actually be a genetic condition called non-congenital adrenal hyperplasia, which again mimics some of the symptoms of PCOS, but would require a totally different treatment plan to address. If you have type B, you may also want to have SHBG, the sex hormone binding globulin, tested. Now, SHBG is one of the proteins in our blood that can bind to testosterone. And if your SHBG levels are low, it is again an indicator of higher amounts of free testosterone, which can then bind to our cells and cause some of this abnormal hair growth, acne beyond adolescence, and problems with our menstrual cycle. And typically oral contraceptives or metformin are prescribed to increase SHBG, but if you have endometriosis, those medications often lower SHBG. And so if you have both endometriosis and PCOS, you will need to talk to your doctor about what is most appropriate for you. If you have PCOS type B, you are also probably going to want to look at cycle tracking hormones like the luteinizing hormone surge or ovulation predictor kits if you are trying to get pregnant or if you want to be sure you don't get pregnant. For regulating the menstrual cycle, they often recommend for PCOS type B that you take a combined hormone contraceptive. So that is going to be birth control that has both estrogen and progesterone in it. If CHCs are not enough, they may look at prescribing anti-androgen, potentially metformin, letrozole, clomiphene, or potentially IVF injections for fertility. Now, unfortunately, type B PCOS can often be overlooked because when we do that ultrasound of the ovaries, they look normal, but your hormones and your lab tests can really tell the story of what is going on with you. If you have PCOS type C and you experience regular menstrual cycles, but high androgens and polycystic ovaries, these are the additional tests that you might want to undergo. If you were originally diagnosed with PCOS using the anti-Muralian hormone, then you may want to have an ultrasound done of your ovaries just to ensure the polycystic ovary morphology in your body. You may also want to have SHBG tested. That is the sex hormone binding globulin. That is just a protein in the blood to which testosterone can bind. And if you have low amounts of SHBG, it is likely one of those indicators that you have more free testosterone floating around in the blood that's going to be available for our other cells to take up that testosterone, and then it can be used to, create these things like abnormal hair growth and acne past adolescence, and some of the problems or irregularities with your menstrual cycle. If you have low SHBG, typically oral contraceptives or metformin are prescribed, which can increase the SHBG. However, medications for endometriosis tend to lower SHB levels. So if you have both PCOS and endometriosis, you'll need to talk to your doctor about what is the most appropriate prescription or rotation of these medications for you. Now, whether your PCOS was diagnosed by testing your AMH levels or by having that ovarian ultrasound, over time you may want to keep an eye on your AMH levels. AMH is often elevated in PCOS because it is secreted by ovarian follicles due to an increased number of immature follicles. And some research suggests that high AMA is not just a symptom of PCOS, but actually could be playing a role in the development or progression of PCOS. So over time, knowing, what is normal for you and seeing if there are any changes in your AMH level can help you understand what might be going on with your PCOS. PCOS type C is tricky because it is masking itself with your regular menstrual cycles. But elevated androgen levels can still put you at risk for type 2 diabetes, cardiovascular disease, endometrial cancer, abnormal hair growth, and mental health conditions. So don't skip out on doing your testing. If you have irregular menstrual cycles and polycystic ovaries, but normal androgen levels, you have type D PCOS. PCOS phenotype D typically has the lowest rates of insulin resistance and the lowest risk of metabolic disease. However, that doesn't mean that you don't need to be testing for things over time to keep an eye on your health. If you're trying to get pregnant or avoid pregnancy, then you would want to be tracking your cycle hormones. So making sure that you're keeping an eye out for your luteinizing hormone rush, which can indicate ovulation, or using an ovulation predictor kit. For menstrual regulation, they oftentimes recommend combined hormone contraceptives, which would mean a contraceptive that has both estrogen and progesterone in it. If CHCs aren't enough, then they might recommend anti-androgen specific medications or things like metformin, letrozole, clomiphene, potentially even IVF if you are having issues with fertility. Type D patients also probably want to keep an eye on their AMH levels. AMH is often elevated in PCOS because it is secreted by ovarian follicles due to an increased number of immature follicles. And some research suggests that elevated AMH is not just a symptom of PCOS, but can actually play a role in the development and progression of PCOS. So people with type D might want to keep an eye on AMH just to understand how or if their PCOS might be changing. Now, if you're in phenotype D, don't skip the insulin or the lipid tests just because estrogen levels are normal and you're probably in a normal range body weight. You are in the group that would probably most benefit from early intervention and being able to use nutrition and lifestyle strategies as your primary management tool rather than having to rely on medication like some of the other phenotypes usually have to. So as a little bit of a recap of the testing that you should get done by phenotype in addition to those core tests. If you are in phenotype A, classic PCOS, you want to make sure that you're testing your insulin, your androgens, your sex hormone binding globulin, your lipids, and potentially doing a pelvic ultrasound to keep an eye on your ovaries. If you have phenotype B or non-PCO PCOS, you are going to want to keep an eye on your androgens, ovulation tracking if you're trying to get pregnant or avoid pregnancy, and definitely get an adrenal panel done to ensure that you actually have PCOS and not a different condition that is causing those symptoms. If you have PCOS type C or ovulatory PCOS, you also are going to want to keep an eye on your androgens, potentially get an ultrasound of your pelvic area, keep an eye on your insulin and insulin resistance metrics, and your sex hormone binding globulin. And if you have phenotype B, normal androgenic PCOS, keep an eye on your ovulation tracking, anti-Mullerian hormone, insulin, and blood sugar levels. And then definitely make sure that you are ruling out thyroid or prolactin issues. Because your PCOS likely looks different than other PCOS patients, we want to make sure that you are treating the appropriate condition. Almost every PCOS patient that I have talked to is trying to figure out the appropriate nutrition and lifestyle recommendations for their type of PCOS that is actually going to work. 98 million Americans have prediabetes, and 90% of them don't even know it yet. In this video, I am going to give you the very quick and dirty on insulin resistance. Everything you need to know to get started reversing your prediabetes, but not so much that you get overwhelmed and confused. Prediabetes is why I became a dietitian. Today we're breaking down what insulin resistance really is, why it matters, and proven ways to reverse it. Science, not hype. So let's get started with what even is insulin resistance. Insulin is a hormone that is made by your pancreas. It helps glucose, or sugar, enter your cells to make energy. If you're looking for a metaphor, we often say that your cells have doors on them, and those doors need keys in order to open. And insulin is the key. For the sake of extending this metaphor across the entire video, imagine that your cells are like a private club, and the club has a doorman that is sitting outside and needs a password to let you in. You are the blood sugar, and insulin is the password that the doorman needs to hear. There's some nuance to that, but that will be in a longer video. When you have insulin resistance, your body stops responding well to that insulin, and so it starts to create more. Now, to bring it back to our metaphor, it would be like if this club had an extremely loud DJ set happening inside, and the doorman just couldn't hear you as well. So in order to get in the door, you shout the password louder and louder. The end result is the same. You get into the club, you get out of the street, but you had to work a little bit harder to make it happen. When your body does that extra work, it's called compensatory hyperinsulinemia. Your pancreas is compensating for the resistance of your cells by creating more insulin. Now, imagine that doorman is an old, grizzled guy that has been standing outside of that club for years, and his hearing is just starting to go on top of the very loud music that's coming from inside. You can keep shouting the password louder and louder so that he can hear the message, but eventually you are probably going to give up. Maybe you end up just grabbing a beer and sitting in the street rather than entering the club. Now, more and more people are also yelling the password at the doorman, but they can't get in either because he can't hear them. And a crowd ends up forming outside of the club, just in the street, kind of loitering, hanging out, clogging up the street in front of the club. This leads to your group potentially causing all kinds of problems outside rather than getting into the club and having a good time. Now, this is is how insulin resistance turns into prediabetes. Your body is no longer able to keep up by producing a little bit more insulin. And so you have more and more sugar that is just pooling in your bloodstream. Prediabetes is when there's maybe a small crowd of people outside of the club. As that crowd grows bigger and bigger, this is when it is turning into full-blown type 2 diabetes. And just like people loitering outside of a club, a small group is easy to deal with early intervention. But a huge group of people can cause systemic issues, and it's just a lot harder to reverse. Same thing in your body. Pre-diabetes is reversible. With changes that we're going to talk about, once you progress to full-blown type 2 diabetes, it is just a lot harder to walk yourself back. I said it in the intro and I will say it again here. More than 1 in 3 American adults has pre-diabetes and 90% of them don't know it. That very certainly could be you. So now you understand how pre-diabetes and insulin resistance work. Let's talk about what causes pre-diabetes and insulin resistance. There are 7 major factors that contribute to developing insulin resistance and prediabetes. 2 of them are things we can't really control: genetics and age. You are going to get older, and the genetics you were born with, you are pretty much stuck with. We are going to talk about the 5 modifiable risk factors. The first one is having excess body fat, especially in your midsection, in your abdominal section. Now, males, men, and postmenopausal females, they have a higher likelihood of storing their excess calories in their midsection, as opposed to premenopausal females who store their excess calories in their legs, their thighs, their hip. And when your extra weight or your extra adipose tissue is stored away from your midsection, it's a little bit more protected. But that doesn't mean that premenopausal women have no risk of developing type 2 diabetes, insulin resistance, prediabetes. They certainly do. So in addition to having more body fat and where that body fat is located, physical inactivity and or low skeletal muscle mass can increase the risk of developing prediabetes and insulin resistance. Only about 23% of American adults meet the physical activity guidelines, which is 150 minutes of moderate intensity exercise or 75 minutes of high intensity exercise per week, plus 2 resistance exercise sessions. Now, number 3, high sugar, high glycemic index diets can increase our risk of developing type 2 diabetes, and that is because we use insulin to digest carbohydrates. The more we have to digest carbohydrates, the more insulin we'll have to use. Over time, that can cause our pancreas to get a little bit tired. Now, this video, this channel, is never going to be the type of channel that strongly supports very low carbohydrate or a ketogenic type of diet, but we as Americans tend to be eating more refined grains and added sugars when we choose carbohydrates, as opposed to choosing higher fiber carbohydrates, fruits, vegetables. So we need to be shifting the carbohydrates that we eat rather than thinking we can't eat carbohydrates at all. Poor sleep is also a big contributor to the risk of developing insulin resistance and prediabetes. It's not just your brain that stays tired if you don't sleep enough. Your pancreas can also get a little lazy when you haven't gotten enough sleep. And so it might not release enough insulin. That sugar is going to pool in your bloodstream. When we don't sleep enough or we get poor quality sleep, we are also more likely to crave high energy, high sugar, high calorie foods to fill that energy gap that we're experiencing because we just didn't get enough rest. Chronic stress, which can include lack of sleep, also impacts our body's normal hormone balance. You've probably heard of the fight or flight mechanism. Well, the opposite of fight or flight is what's called rest and digest. If we are never fully getting into that de-stressed hormonal state, we are just not digesting in the way that we should be, which means we are impacting how and when and how much sugar is actually getting into the appropriate cells. Now, research is also showing that our gut health can contribute to developing type 2 diabetes, but that is quite literally another video that I will link to down in the description. All right, let's get into the plan. Now, research says there are 4 things that you can do starting right right now, starting today, starting with your next meal, to reverse or prevent your insulin resistance or pre-diabetes. Everything else that people on the internet are trying to sell you are just bullshit. Let's talk about nutrition changes that actually reduce your risk of developing insulin resistance. To put it plainly, increase your fiber intake, reduce your added sugar intake, and reduce your saturated fat intake. The diabetes plate from the American Diabetes Association is a good visual place to start. It specifically says you want half of your plate to be non-starchy vegetables, a quarter of your plate to be grains or starches, and a quarter of your plate to be lean proteins. That could be meat, that could be dairy, fish, could be maybe beans, tofu, soy. Eat 3 to 5 meals per day that look like that diabetes plate. There are no foods that are off limit as long as the portion sizes and the combination fit that framework. If you're the type of person that likes numbers and goals, the recommendations here would be 25 to 35 grams of fiber per day, 2.5 cups of fruit, 2.5 cups of vegetables per day, and less than 40 grams of added sugar. Even less, honestly, because you are at an elevated risk of insulin resistance, I would maybe set your goal at 25 grams of added sugar per day. Max. If you need some inspiration or some ideas, you can download my fiber ebook. It is free. I will link to it down in the description. There are a ton of different recipes, no cook recipes, even fast food orders, and you can combine any 3 meals in that ebook to hit your 25 to 35 gram fiber goal in a day. Now, research shows that working with a registered dietitian can increase people's success in improving their diet and lower their risk of developing chronic diseases. So if you have the ability to work with a dietitian, I highly recommend it. If you don't have the ability to work with a dietitian, I would love if you subscribed to this channel. Maybe leave me a comment on one of these videos and I will provide as many resources and answer as many questions as I can. The second thing you can do to start reversing your pre-diabetes and insulin resistance right now is build more muscle mass and take a 5-minute or more walk after every single meal. Both cardio and resistance training have been shown to improve insulin sensitivity. However, combined exercise, meaning both resistance and cardio exercise, have been shown to be most effective, and I recommend focusing on building muscle mass. Skeletal muscles don't require insulin to let blood sugar in. They only require movement. Rather than having a doorman outside of the door, it's kind of like an automatic sliding door where you move and it opens. The more muscle you have, the more sugar comes in. And the more muscle you have, then you move that muscle in a 5 or more minute walk after you eat can help you really pull sugar out of the blood. Number 3 is improve your sleep and develop a stress management system. Aim for 7 to 9 hours of sleep per night. Even if you think that you are the type of person that, can thrive on 6 or few hours, maybe your insulin resistance is telling you you can't. When it comes to stress reduction, especially these days, it can be really hard, but even just a couple minutes of deep breathing or box breathing can be useful for your body to get into that rest and digest. Then, if you have the ability to access a therapist, that can also really help with stress management. And number 4, I'm going to give you a couple of supplements and medications to consider because I know that is everybody's favorite. Vitamin D has been shown to improve folks' insulin sensitivity, and most Americans are not getting enough vitamin D either through diet or through sun. And so a vitamin D supplement is typically recommended for folks with prediabetes or insulin resistance. Another supplement is berberine, which is part of traditional Chinese medicine and has been shown to lower blood sugar levels. GLP-1 receptor agonist medications like Ozempic and Wegovy, maybe even tirzepatide medications like Zepbound or Mounjaro, have also shown to improve insulin resistance and prediabetes, but they are absolutely harder to access and more expensive. Now, research shows that reversal of insulin resistance and prediabetes can begin in 3 to 6 months' time. So it's not going to happen overnight, but with with consistency, it also doesn't have to take forever. Lifestyle intervention programs like the National Diabetes Prevention Program have also shown really great success for people in reversing their prediabetes and insulin resistance. So I will link to the NDPP website where you can see if there is a program in your area that you are a candidate for and can join. Last thing I'll say here is rather than jumping in and making it as difficult as possible, start with small, sustainable changes. If you found this helpful, I would love if you subscribe to this channel, maybe share it with 2 friends. 1 in 3 folks has diabetes, could be any of you. Now, if you're struggling with your blood sugar, your body weight, maybe PCOS, sleep apnea, to the point that you don't think that lifestyle intervention like this is going to be enough, I highly recommend you check out this video, which is my GLP-1 medication masterclass, where I talk all about things like Ozempic, how they reduce your risk of developing all kinds of chronic diseases, and that might be useful for you if that is a journey that you think you want or need to go on. Don't forget to download that free fiber ebook. Did you know that up to 80% of people with PCOS have some level of insulin resistance, even if they're not overweight? But what is insulin resistance, and how does it drive PCOS symptoms like irregular menstrual cycles, acne, and fertility issues? Let's break it down today. Insulin is a hormone that is produced by your pancreas. After you eat a meal, your body will release that insulin, which allows sugar to move out of your bloodstream and into your cells in order to make energy. When you have insulin resistance, your body has to produce more insulin in order for your cells to respond at the same level as it did before. And if sugar can't get into your cells, it means it's just pooling in your bloodstream, which can cause other health conditions, and over time, you can actually die. And that is what used to happen to people with type 1 diabetes before we learned about insulin, how it worked, and how to make it into medicine for those folks. Now, for a while, most people with insulin resistance are able to keep their blood sugar levels in an appropriate and healthy range. However, they're doing it with a higher amount of insulin, and that high amount of insulin can be causing damage to your cardiovascular system. It can be causing you to gain weight. It can just be causing other systems of your body to be functioning in a little bit different way. And that is partially how it contributes to our PCOS symptoms. Science is now really finding that PCOS and insulin resistance have what's called a bidirectional relationship. A bidirectional relationship means as your insulin resistance gets worse, your PCOS also gets worse. And as your PCOS gets worse, it can make your insulin resistance worse as well. So it's this vicious cycle between these 2 conditions, which makes both of them very challenging to improve. Insulin resistance doesn't just affect your metabolism, it actually impacts your hormone health as well. Okay, stick with me here because we are going to get pretty sciencey. High insulin levels stimulate a cell in the ovaries called the theca cells. Now, theca cells provide structure and support to the ovarian follicles, but they also stimulate androgen production. And androgen production is what makes typically male reproductive system hormones like testosterone. All females are going to produce some amount of androgens because they are the precursor to our typically female reproductive hormones, estrogen and progesterone. In people without insulin resistance, females will create a low level of androgens across the menstrual cycle. And in the middle of the menstrual cycle, the low amount of androgen will allow a spike of luteinizing hormone. And that spike of luteinizing hormone is what tells the body it's time to release a mature egg. Now, if androgen levels are high, we won't have that spike of luteinizing hormone, which means we won't produce or push out a mature egg, which means we are going to experience some disruption in what would be a typical menstrual cycle. And that is something that's pretty common in PCOS patients. Not every PCOS patient has a disruption in their menstrual cycle where they have these really long menstrual cycles or irregular periods, because there are different types of PCOS. And if you're not sure which type of PCOS you have, I have a whole video laying out what type of PCOS you might have based on your symptoms. But for many folks, this insulin resistance then causes high androgen production, and that high androgen production disrupts our typical menstrual cycle. And that is a big part of why PCOS patients typically have a difficult time getting pregnant, because they're not regularly releasing a mature egg due to these high androgen levels. And those high androgen levels may be a result of insulin resistance and high insulin levels stimulating the theca cells all the time. The thing about hormones is they can actually bind to any cell in the body that has a receptor for them. All of our typically reproductive hormones, like testosterone, estrogen, and progesterone, they actually have receptors on cells or tissue types all over the body, not just in the reproductive system. So things like testosterone, estrogen, progesterone, they can actually bind to cells in our brain, in our adipose tissue, in our cardiovascular system, our heart, in our nervous system. We are actually able to experience, and we do experience, effects of our different reproductive hormone levels all over our body. And this is why males typically store most of their adipose tissue or their extra fat in their midsection, whereas females typically store most of their body fat or their excess calories in their hips, their butt, their thighs. That is because estrogen and testosterone can bind to those adipose cells and direct which area of the body is going to store those calories. When females have insulin resistance and their theca cells are producing more androgens, they may also experience this belly fat that we typically see in males, because that testosterone is saying, hey, we like to store our excess calories in the midsection rather than, say, in the booty. And that belly fat, again, another typical PCOS symptom that we see in lots of PCOS patients. Now, testosterone can also bind to the skin, and high testosterone levels binding to our skin cells can cause things like hair growth and acne, another two very common PCOS symptoms. And it goes back to testosterone being able to bind on these different tissue types that actually have nothing to do with our reproductive system. Excess testosterone can actually also bind to the pancreas. And remember, the pancreas is where we produce insulin. Binding causes our body to produce even more insulin. So now we have insulin resistance and high insulin binding to our theca cells, causing us to produce more testosterone. And then this testosterone can go around and bind to our pancreas, which then causes us to create more insulin. And this is how that vicious cycle I mentioned at the beginning really happens. Now, insulin resistance and PCOS can also be caused by things like chronic inflammation, stress, and other hormones that impact our metabolism, as well as genetics. But there are some pieces of this that we can manage or we can change, improve with lifestyle management. Some of them might require medication. Now, insulin resistance is why I became a registered dietitian. I'm going to give you some of my best tips to reduce insulin resistance in people with PCOS or without PCOS. Now, number one, despite what you have probably been told, I don't want you to cut carbohydrates completely out of your diet. What I want is for you to think about shifting your carbohydrate intake from more of our refined, high glycemic index carbohydrates that are pretty typical, pretty common in the American diet. Switch over to more lower glycemic index, higher fiber carbohydrates. So things like whole grains, oats, lentils, beans, fruit, vegetables. I want you to focus more on those carbohydrates and less on your refined grains, things like white rice, white pasta, white bread. I have a whole video that I will link down below that is all about the evidence-based recommendations for diet, supplement, and herbs based on your type of PCOS or the PCOS symptoms that you are trying to manage. Now, number 2 is you want to be getting regular physical activity. Both cardio and resistance exercise have been shown to improve insulin resistance. A combination of both cardio and resistance exercise is most effective, but I really want you to focus on building muscle mass. The reason I want you to build muscle mass is because having muscle mass and then moving that muscle allows us to pull sugar from the bloodstream without insulin. Muscles are able to work a little bit different than other tissues in the body. So if you have more muscle, they can pull more sugar from the blood when you start to move them. And that is really important because anytime we can clear the blood of sugar without insulin, we are actually improving our insulin sensitivity, which is the opposite of insulin resistance. Now, science says that moving your muscles after a meal for just 3 minutes can actually improve your insulin sensitivity. So you don't need to be doing, really long walks after every single meal if it doesn't make sense for you. You certainly can, but you want to build those muscles and then move them for a few minutes after your meals to really help your body metabolize whatever you just ate. If you are on an airplane or you're in a meeting, a lunch meeting, and you've eaten something, just bouncing your leg or doing a little bit of calf raises, even maybe like moving your arms, if you have muscle and you are moving them, that will help to metabolize that sugar, pull it from your bloodstream without having to do anything else and without using insulin. So have muscle, move them at least a little bit after your meals. Now, those two things, increasing the amount of fiber that you're getting in your body and in your diet, reducing the amount of added sugars and refined grains, and then building muscle and moving that muscle, those things have been shown to reduce your insulin resistance in as little as 3 to 6 months. So if you commit to those two things, over time, you are probably going to see some improvements in your insulin resistance and then maybe also your PCOS symptoms. Now, the third recommendation I have for you is other lifestyle and potentially medical support for your insulin resistance. Now, that might mean getting better sleep, getting more sleep if you are not getting enough or getting high quality sleep. And that is partially because our pancreas just works better when we've gotten enough rest. You may just also need a better system to manage your chronic stress. That might be breathing, it might be going to therapy. Finding a release system that is healthy for your stress can reduce some of the other hormones that can cause insulin resistance. You may also want to explore medication like GLP-1 medications, myo-inositol, or metformin, which are 3 medications that have been shown to reduce insulin resistance in people with or without PCOS. And you can talk to your doctor if those are appropriate for you. Now, personalized medical nutrition therapy, which is just specific management of your PCOS and your PCOS symptoms, done in conjunction with a registered dietitian, has been shown to improve insulin resistance better than doing it on your own. So if you can afford or you can access a registered dietitian, it may be really useful to do so that you can have an educated, science-backed plan and you can have accountability from that dietitian. The best diet for PCOS is the Mediterranean diet. Why I say that? The research that supports the Mediterranean diet and PCOS, and how to actually implement the Mediterranean diet in your everyday life without having to become a personal chef or spend a bunch more money on groceries. First, where did I even come up with this idea that the Mediterranean diet is the best for PCOS? Well, that is actually the recommendation for most types of PCOS according to the International Evidence-Based Guideline for the Assessment and Management of PCOS. They collected all of the existing research on different types of diets in PCOS patients, and what they found was that the Mediterranean diet is actually what seems to manage and even sometimes reverse most of the symptoms of PCOS better than any other diet or diet plan. This is Penelope. She is my 14-week-old new puppy, and she really likes to chew on cords. So I'm gonna hold her in my lap for a while so she stops chewing on cord for my lamp. Specifically, some of the symptoms of PCOS that the Mediterranean diet has been shown to address are: one, insulin resistance. Insulin resistance is a big driver of PCOS, and PCOS can actually be a driver of insulin resistance as well. The Mediterranean diet has also been shown to have some benefits in managing infertility, irregular periods, abnormal hair growth, and belly fat that can often come along with PCOS. Now, there are slightly different recommendations for PCOS diets according to what type of PCOS you have. But for types A and B, and I think even type C, the Mediterranean diet is actually what is recommended. And then type D, they actually recommend you just follow the dietary guidelines for Americans. And the dietary guidelines for Americans actually include the Mediterranean diet as one of the healthy dietary patterns that can work with the DGAs. So ultimately, following the Mediterranean diet can be a really useful plan for everyone with PCOS. Now, if you're not sure what type of PCOS you have, another one of my videos help you figure out which type of PCOS you have. And once you figure out which type you have, it can be really useful in figuring out a plan that is really personalized to your experience of PCOS. Now, I will link that video right up here, but also down in the description of this video as well. In this video, though, we are going to dive into the Mediterranean diet. PCOS is not only a reproductive condition, it is also a metabolic and an inflammatory condition as well. Most people with PCOS are also experiencing some level of insulin resistance, no matter their weight. That insulin resistance may or may not be all the way to prediabetes or type 2 diabetes. What that insulin resistance really means is that your body's tissues, your body's cells are just not responding to insulin as well as we think it should be. And when your body is not responding to insulin as well, your body starts to make more insulin. Another thing that high insulin levels do is they trigger cells in our reproductive systems to produce more androgens. And androgens are the hormones, the reproductive hormones that we typically see in higher amounts in males. Because our PCOS patients are experiencing insulin resistance, they're making more insulin, and that higher level of insulin is causing our body to produce more testosterone. And those higher amounts of testosterone are then causing issues like infertility, irregular periods, belly fat, facial hair. It all goes back to this insulin resistance that PCOS patients are experiencing. So the Mediterranean diet has been shown really effective in PCOS patients and in non-PCOS patients at addressing those metabolic and inflammation concerns that I mentioned occur in addition to the reproductive system concerns with PCOS. The Mediterranean diet is rich in what we call monounsaturated fats from olive oil, from nuts. The Mediterranean diet is also high in fiber and antioxidants that we get from fruit, from vegetables, legumes, whole grains, and those antioxidants and the fiber play a major role in lowering our inflammation and stabilizing our blood sugar levels. And then we also get omega-3s from the Mediterranean diet. This again is a specific type of unsaturated fat, and we oftentimes get omega-3s from fish and nuts, and they have also been shown to further reduce inflammation in the body. And that is, again, really important because inflammation can be another major driver of insulin resistance. While there is a lot of support for the Mediterranean diet in PCOS patients, the Monash guidelines that I mentioned at the beginning of this video also recommend that any dietary plan that you follow should be personalized and sustainable. This video is not going to be about quitting your job, moving to the south of Italy, hiring a chef to eat the perfect Mediterranean diet. Although if you can, that sounds awesome. You should do it. This video is really about how to incorporate the principles of the Mediterranean diet in your real life. So the diet is actually mostly plant-based and recommends you eat a lot of fruits and vegetables, especially leafy greens, every single day. You should be consuming whole grains like whole wheat bread, quinoa, couscous, and legumes like beans and lentils. Healthy fats, especially olive oil as your primary fat, and some nuts and seeds, and the Mediterranean diet recommends that you mostly season your food with herbs and spices, not table salt. The Mediterranean diet says you should eat fish 2 to 3 times per week. Most of your other servings of meat should be chicken, and you should save red meat for maybe just once or twice a month. Low-fat dairy can be consumed in moderation, and eggs should be included a couple of times a week. Mediterranean diet also contains moderate red wine consumption, but for PCOS specifically, the international guidelines have said you should skip the red wine and get the polyphenols from green tea instead. Sorry. The Mediterranean diet also recommends regular physical activity, lots of water, and slow meals with family, friends, companions as often as possible. So as I mentioned, in practice, this oftentimes looks really similar to the My Plate guidelines that the Dietary Guidelines for Americans recommends. So in practice, it's about half your plate, colorful vegetables and fruits. Things like spinach, tomatoes, berries, citrus. Deeply colored fruits and vegetables are better than the light colored fruits and vegetables. For instance, iceberg lettuce or romaine lettuce, those are kind of light green colored lettuces. And what they would recommend is doing more like spinach, kale, if you like it, collards, those deeper green leafy greens, because they are going to have more of those plant compounds that are more anti-inflammatory. A quarter of your plate should be protein. Again, fish, chicken, beans, lentils, maybe even tofu. About a quarter of your plate should be grains. So whole grains or legumes. Quinoa, farro, barley, chickpeas, couscous, those sorts of dense carbohydrates that are going to be high in fiber. You'll also want to add extra virgin olive oil fairly generously and include nuts and seeds pretty often. Now, especially for people with insulin resistance, like most people with PCOS, it also helps to pair your carbohydrates with a protein or a fat or maybe both to even further slow down that carbohydrate digestion. Things like hummus, maybe a little bit of cheese. If you've been here before, you already know this, but for those of you that are new, yes, I'm a registered dietitian, but I don't really cook. I don't really like to cook. I prefer to just put components of meals together. And I think that is still possible while following the Mediterranean diet. So what that might really look like in a day, I would start at breakfast with a low-fat Greek yogurt, a plain Greek yogurt. I always recommend plain because the flavored ones, when they add the fruit in, they also add some sweetener, some sugar in there. I would just prefer, and it's going to be better for your health and your insulin resistance, to cut as much added sugar out of your diet as possible. I would add a bunch of berries on top. Then I would also put some walnuts or some pecans on top, and I might even throw a small portion of some dark chocolate chips on top as well. For lunch, I would have something like a lentil quinoa grain bowl. I say lentil and quinoa because when you put them together, they make a complete protein, just like a meat. They're going to have everything in there that a meat would. It's just coming from 2 different plant sources. Those are also both whole grains. So again, you're going to be getting some good fiber in there that is going to slow down your carbohydrate digestion. I would probably add some things like tomatoes, cucumbers, maybe some lemon juice for some flavor, feta, and I would put something like chicken or maybe even tuna on that salad as my protein, maybe even tofu. Any of that would totally work. For greens, if I wanted some greens in that salad, I would pick something like spinach. I personally don't really like kale, So spinach could go in there really easily. For dinner, I like to get like frozen salmon burgers. I think that would be a really nice way to have some fish without having to necessarily cook fish. I would have it for dinner, so I wasn't making fish at the office, right? But I might do something like a salmon burger. I could put it on a spinach salad, or I would maybe choose a whole wheat bun. And then I would have some roasted veggies on the side, like depending on what's in season, what's fresh, maybe like some broccoli, some Brussels sprouts, some asparagus, some cauliflower, zucchini, whatever, right? Some roasted veggies on the side, sauteed, roasted with some olive oil, put some seasoning on top, some herbs, some spices to give it a little bit of flavor. Maybe even make like a tzatziki sauce out of that Greek yogurt to put on top of my salmon burger. And then for snacks, I mean, I'm gonna have snacks every day for sure. I might do like hummus with veggies or whole grain crackers, something like that. I might even do something classic, something old school, like apples and peanut butter, celery and peanut butter. You could do something like cottage cheese with everything bagel seasoning, cottage cheese with some fruit on top, an olive tapenade plate if you're into olives, just as good as olive oil. You could do like avocado toast with an egg on top, avocado toast with some feta on top. So that's kind of how I would structure my day without having to do a ton of cooking. If you are into the canned fish craze these days, they do sell a lot of those tinned fish in olive oil. So that could be a really handy thing to keep in your pantry. Open up, maybe have on some toast, have on some whole grain crackers. So I think there's a lot of things that you could do to build a Mediterranean diet that don't have to be overly complicated, even overly expensive, and they're still going to be useful in helping manage your PCOS. Now, remember, consistency is going to beat restriction. So make sure that you are incorporating those Mediterranean type principles into your real life with foods that you actually enjoy, that you could see yourself eating, for the rest of time potentially, because you are likely going to be managing your PCOS for the rest of time. I actually made a whole 7-day meal plan that you can download for free. I will link to it down in the description of this video. Again, that is guidance. That is a place for you to start and then customize from there with the foods that you really enjoy. Thank you so much for watching this masterclass. Now, I mentioned a couple of free downloads in those videos. Those are all absolutely still available, and I will link to them down in the description of this video. If you are interested or you want to continue to learn more, especially about insulin resistance or weight loss medications, both of which are very much related to PCOS. I have some more videos on those topics, and I would love to answer any questions that you have after this masterclass. So if you leave those in the comments, I will happily answer those questions in as much depth as I possibly can. See you in the next one.